Good morning, everybody, and welcome to the MDU's first interactive online webinar. This is a very exciting moment for us. The idea of beaming CPD to you where you are, be that in your pyjamas at home or indeed in your office at work. Hopefully this will be the first of many of these webinars where you are able to partake in interactive CPD where you are, as opposed to having to travel to a meeting, for example, which may be difficult. What I would like to just some general practical things to begin with. You will see that you have a box linked to the webinar portal which allows you to ask questions. Now please feel free to ask questions as you go along. We'll probably answer them at the end just to make things a bit more straightforward, but if things occur to you, please do simply type them into the question box. We will also be asking for your views. This will be, insofar as it can be, an interactive presentation, so please type your answers into the questions box as we get to those parts of it. And there will also be a poll in which we'll ask you to vote for whatever the correct answer is, and that will also appear on your screen. If you think of any ideas of topics you would like to have further webinars on, then please do also add them to the questions box. And we'll also be grateful for your feedback once this presentation is over, to have an idea of what would be useful for you, whether you enjoyed it, and ideas and things for the future. So thank you for joining us. As you know, today we're going to be talking about dealing with complaints. And as an overview to start with, we're going to be discussing why is it important to get it right? Why it is important to get your complaints responses dealt with and complaints closed down as quickly as possible. We're going to talk about what is a complaint and the different types of complaints that can come your way and what you should do with them as a consequence. And we're going to talk specifically about how you should respond. What are useful things and useful hints and tips practically in terms of responding, and we'll have some case scenarios in which you can give us your thoughts as we go on. And then, probably most importantly, we're going to talk about how to avoid them. What kind of things can you do to try to reduce your risk of becoming subject of a complaint? So to give you some background about why it's important, we have some statistics from the Information Services Divisions of the NHS in Scotland who, as you may know, collect all of the data with regards to complaints. You might remember this particular set from 2012-2013 because these were the ones where the stats were initially reported as showing a reduction in complaints, but actually it turned out somebody had made a serious error in the statistics department and they had to reissue the statistics later on, showing indeed that complaints had continued to increase. In regards to the secondary care setting, in 2012-2013 there were 9,161 complaints, which was an increase of 13% on the previous year. In the Family Services Division, which includes general practice, there were 6,130 complaints, and that represented a 39% increase in complaints on the previous year. So complaints are constantly on the rise, and the complexity of complaints is also on the rise, and the number of areas where a complaint can go to ultimately if it's not resolved quickly is ever increasing, and that's why it's important that we understand how to deal with them quickly and get them closed down. Now, interestingly, what we would like to do now is go to a poll to ask you what percentage of these complaints as a whole do you think were actually related to the treatment that people received. That means the care that was provided to them, the actual medical treatment or intervention. What percentage of complaints do you think were actually related to the treatment? And we're going to go to the poll, which will appear on your screen. You'll see you've got a number of choices there. I can see that people are voting. About 3/4 of the people who are attending are voting. We're nearly there. If you're not quite sure which one to pick, have a guess. So what percentage of complaints received were related to treatment? Okay, interestingly, the percentage related to treatment was in fact 35%. So only 35% of all complaints that are received are actually in relation to the treatment they provided. And the next biggest sort of area of complaints is in relation to staff attitude. A third of complaints are about how somebody spoke to them, whether they felt somebody was rude or rushed. And that's a really important thing to bear in mind in your own day-to-day practice. None of us go to work in the morning deliberately setting out to upset patients, but 33% of complaints that are received are about exactly that. The doctor didn't listen, I didn't feel that they were paying attention to what I was saying, those kind of things. So I think that's a really important thing for us to bear in mind in our day-to-day practice in terms of avoiding becoming subject of a complaint. And I think the important thing is that you are likely to receive one, if not several complaints during your lifetime, and they are not pleasant things to be involved in, and what we are trying to do in terms of raising awareness about complaints is to make sure that if you get one, that you know what you're doing, you know what, how things should progress, and you know the best way to get it closed down quickly. So why is it important to get complaints responses right? It's important to get it right because patients deserve an open and honest response. I mean, if you were providing, if you were complaining about a service that you had received, you would expect to get an apology, you would expect to have an investigation into what your concerns were, and you would expect to have an open and honest explanation. As medical professionals, we also have a GMC obligation to provide an explanation, and I'll read you exactly what paragraph 55 of Good Medical Practice 2013 says, and it says, you must be open and honest with patients if things go wrong. If a patient under your care has suffered harm or distress, you should put matters right, if that is possible. You should offer an apology, and you should explain fully and promptly what has happened and the likely short-term and long-term effects. So we have a GMC obligation to make sure that if patients are unhappy or if indeed something has gone wrong, that we provide an open and honest response. Another reason that's particularly important for doctors to ensure that they get it right is because doctors are subject to the spectre of multiple jeopardy. And by that, what we mean is that one clinical incident can give rise to a number of outcomes. So for example, if we take an example of a clinical incident, something that has taken place that perhaps shouldn't have done. As we've discussed, that can become the subject of the NHS complaints procedure, and there is then the option to resolve things locally, which is what we're trying to achieve, or that the complaint goes on to the Health Service Ombudsman at a later date. But that one clinical incident can also give rise to a number of other avenues of investigation, and one of those would be that it could end up in the civil court as a claim, so you could find yourself facing a claim for clinical negligence. There is also the opportunity where the police may become involved if, say, for example, a patient were to have died as a consequence of some medical intervention or otherwise. There is the potential that the police may become involved and that there may be a criminal investigation. It is, of course, possible that an incident can give rise to a disciplinary investigation, and that can be a long and drawn-out disciplinary process. It may involve investigations of other aspects of your practice in addition to the clinical incident that gave rise to the concern in the first place. There's the possibility you may find yourself subject of a performance assessment, and indeed exclusion for practice or dismissal if it were deemed to be significant enough to warrant that. And there is also the option that your employer may refer you to the GMC if a clinical incident were deemed to be of significant or have caused significant harm to a patient. And if we move to the GMC, GMC could become aware of a clinical incident either via your employer or indeed via patients complaining directly to the GMC. And it's not unheard of now for patients to entirely bypass the NHS complaints process and go straight to the GMC process, where the GMC will then investigate a complaint. A GMC investigation is what every doctor dreads, and even though it may turn out that there's absolutely no merit in the complaint whatsoever, you will still be facing the spectre, I suppose, of a GMC investigation. And indeed, as we mentioned, if a patient had died as a consequence of whatever the clinical incident may have been, there may well be a fatal accident inquiry conducted by the Procurator Fiscal, and that may lead to you having to appear as a witness at a fatal accident inquiry. Now, the reason it's important to understand why one incident can give rise to all of these things is because if the complaint comes first, and quite often it will do, if the complaint comes first and is closed down successfully to everyone's satisfaction, it significantly reduces the risk of any of these other things happening. If you have a complaint from a family or a patient and you deal with it appropriately at this stage, it may prevent them from going to the GMC as a consequence of being unhappy. And similarly, if you deal with it well at the local resolution stage, it may dissuade people from moving the complaint on further. So this is why it's important to get things right and to try to get complaints closed down at the earliest possible stage. So I think it's important to understand what is a complaint, and it's not documented or written down anywhere in legislation what a complaint is, but in general terms we would advise a complaint is an expression of dissatisfaction that requires a response. Now, there are a number of ways that those expressions of dissatisfaction may come to your attention, and there's kind of things at the fairly minor end of the scale, which we would call comments and concerns, the type of thing that patients would mention to the receptionist on the way out of the surgery, for example, or may phone up and say to your secretary, for example, if they've been unhappy about the length of time they've waited or something like that. So comments and concerns are things which people say that they don't necessarily want to commit to paper and they don't necessarily want to take through the formal complaints process. But it's really, really important to deal with these things quickly and early, because you can nip things in the bud to make sure that they don't progress to a more formal issue. And also, if you can get these things sorted to people's satisfaction early on, it means when they come back, they're not harbouring some ill feeling about an unresolved issue from a previous contact, for example, that might make them more likely to find fault in any subsequent interactions that they have with you. So it's really important with regards to comments and concerns that you train and empower frontline staff. That might be the receptionist in your surgery, it might be the HCA who attends with you in clinic, to make sure that frontline staff are empowered to take on board what patients say to them at those early stages, and insofar as possible try to make it right. These are things which are often about lengths of time people have waited to be seen in clinic, for example. It can be sometimes patients will come out and say, well, that doctor wasn't very pleasant. Things like that people can try to nip in the bud there and then and bring to your attention early on so that they can be resolved before they escalate any further. An honest response on the spot is generally what people want. So, for example, if the clinic is running late for some particular reason, members of staff are off sick, for example, or a patient has been in previously and has taken a lot of clinical time because of an emergency or something like that, if you can provide people with an honest response on the spot about what is going on and how long they're likely to wait, or what might be the reason for why they have waited, in general terms that is often enough to answer people's concerns. A really helpful thing to do with these kind of slightly low-grade grumbling things that people say is to offer them the opportunity to go through the formal complaints process. Often that's enough to stop people in their tracks and say, oh no, I don't think it's that bad. And in conjunction with doing these other things, but providing an honest response and an apology if appropriate at the very early stage, that can often be enough to stop things from escalating any further. And as I say, if these are dealt with well at the first opportunity, then it means they're significantly less likely to become a grumbling, ongoing issue when the patient comes to see you again and again. I think importantly, if a patient brings something up but doesn't want to take it any further, but actually what they've brought is something that is quite serious, it might be a near miss, it might be something which actually, if it were to happen again, may cause difficulty or harm to a patient or escalate further, then it's important to have a significant investigation into those things, even if they're not being formally investigated as a complaint, particularly if you find that there's perhaps more than one patient bringing up something fairly minor or fairly straightforward and it's becoming a pattern. Then I think at that point you would want to be looking at those things and saying, well, actually, is there something here that we need to be addressing? So if we move on now to, let's assume that the complaint that you've received isn't one of these minor concerns or comments that can be easily sorted out on the spot. If we're now moving on to thinking about a formal complaint or a verbal complaint that hasn't been quickly resolved, because importantly, complaints don't necessarily have to be written down. Patients can make a verbal complaint, and if it's not one of these sort of minor concerns that can be sorted out quickly, then that should be considered to be a complaint and should be dealt with through the normal processes, even although the patient has not necessarily written it down. And in those circumstances, what we would suggest that you do is that you write a letter to the patient to say, we understand that your complaint, you have concerns of the following, and you document what it is that you think the concerns are, and give the patient the opportunity to come back and add anything or to correct anything if you have misunderstood. So complaints do not have to be written down. In the vast majority of cases, they usually are. So if we're talking about how to respond, we need to think about, well, what do complainants want when they when they have complained? What is it that they want to receive from you in response? And often what I suggest you do in this circumstance is to think about what would you want? If you had written to your bank to complain of poor service, for example, what would you want in a letter of response? And what we're going to do at this stage, we're going to send it over to you. This is the point where you can type some answers in the questions box and give us an idea of just a few words, sort of descriptive words. What would you want, and what do you think complainants want when they're receiving a letter of response from you? Okay, so we've got some answers coming in. Let me have a look. Yep, so people are saying things like an apology. People want an acknowledgement of their complaint and to express some understanding. People want empathy, an explanation, an apology and an explanation, a genuine apology in a timely manner. I think that's important. We'll come on to timescales. People want honesty. They want an acknowledgement of what has taken place. Absolutely. They want to be taken seriously. They want some action to be taken. They want things to be clear of jargon, and that's really important. Thank you for that, Angela. We'll explain what we mean by avoiding jargon. And people want an apology for their discomfort. Exactly. Thank you for that, Ola. And that's a really important one from Petros, which says people want to know that measures have been taken to make sure it doesn't happen again, and that's absolutely right. And people want to be acknowledged. So we've got lots of things there which are exactly the kind of things that we would suggest. So what complainants want? They want an explanation. They don't want to be made to feel as if there was, there was no merit in them bringing a concern at all. They absolutely want to have an explanation of what took place and what happened. People want to feel heard. They want to understand that you have taken on board what their concern was, and that's a really important thing. And that's quite an easy thing to do, really, in terms of the tone that you provide a response in. People want an apology, and I think that is entirely appropriate. Now, it's difficult sometimes to apologise for things if, when you've done an investigation, you can't find anything that's gone wrong. However, what we always say is it's always appropriate to apologise that someone has been unhappy with the service that they've received. An apology is not an admission of liability. It is simply an apology that things have gone wrong, if indeed they have gone wrong, or that the patient has been unhappy. I mean, nobody wants their patients to go away unhappy, and therefore, presumably, it would be reasonable to say, I'm very sorry that consultation did not go as we would both have liked. I don't think you would have set out the consultation to have gone badly. And therefore it's appropriate to say, I'm sorry that things did not go well. Importantly, and a few people obviously mentioned this in their answers there, people want to know that there will be improvements made to the service if things go wrong. And I think that's a really important part of conducting a complaints investigation. Actually, what can we do differently the next time? And I very strongly encourage doctors, when they're providing responses, to include that in their letter of response. We've investigated this, we realise that this didn't go well, and this is what we're going to do as a consequence. People want willingness to right wrongs, and again that goes along with improvements to the service. But it also means if something has gone wrong, that you're prepared to say, well, we will try and make sure that we can make this right for you. And people want people to take ownership of the complaint itself, that people don't want to be bounced from pillar to post, and they don't want you to be blaming someone else for what took place. What people don't want is denial or trivialization, which is this idea that there's absolutely no reason for them to have complained in the first place. People generally don't commit pen to paper to write you a complaint unless they have been genuinely upset in some way. That doesn't necessarily mean that there's any merit in what they're complaining about, but they've obviously felt aggrieved enough to send you a letter, and therefore I would suggest that you take it seriously and that you reflect back to them within the letter that you understand that they have been upset. They don't want blame. It doesn't do you, it doesn't do your colleagues, it doesn't do us as a profession any favours to be seeking to blame someone else as a consequence of what's happened. You should try, insofar as possible, to stick to the facts that relate to you as an individual practitioner. And then but all you can comment on really is your involvement in the care. If you are the person who's investigating the complaint as part of say a practice investigation or a department investigation, and you weren't necessarily involved, then it's your job to bring together all of the statements from those who were involved to provide a cohesive response. People don't want excuses. Explanations are fine, excuses are not, and it's important that you give explanations for things and not excuses. And people don't want multiple procedural stages. By that, what I mean is they don't necessarily want to be sent from pillar to post, back and forward, trying to sort out their complaint. In essence, if somebody complains about, say, a complaint where they have concerns about what happened in primary care setting and secondary care setting, then a single unified response should be provided with the agencies involved cooperating to provide a single unified response to the patient. Now, in often cases, it might be the patient may prefer to receive letters individually from organisations, and that's fine, but in general terms, you should be aiming to provide a single unified response. So importantly, be sympathetic. We've all been in that position. We've all been in the position where we have received service which is not what we consider to be up to scratch. And therefore, the fact that someone has taken the time to write to you, try to be sympathetic and to convey that empathy and sympathy in the tone of your letter. It is very easy to dash off a draft letter, which if you'd taken a couple of days to just think about it may have had a different tone. And it's not unusual for me to send letters back to doctors to say, you know, a couple of days may have passed, why don't you read this again and consider whether this is what you really want to say? Because none of us like to be subject to complaints. It does get our hackles up, particularly if it can be the patients who you feel you've done the very most for and still remain dissatisfied, and we've all come across those patients as well. But do, insofar as possible, try to keep your response conciliatory in tone and factual where possible. Do take time and seek advice from your medical defence organisation. That is what you pay for. That's the whole point of being a member of a medical defence organisation, is to give you support and also to provide an objective view about what took place. And also we can give a very good idea about tone because we are not emotionally involved in the complaint, and therefore the tone of the letter is much more apparent to us. I can tell who was in a bad mood when they sent a response, for example. Do express regret and apologise if it's appropriate, and don't ever blame anyone else. It doesn't help anybody, and it doesn't really solve the issue for the complainant either. It can often be helpful to discuss with somebody independent, and I will often say, particularly if I feel there may be merit in a complaint, if I feel when I've reviewed the letters of complaint and reviewed the notes and reviewed the case, if I feel that perhaps there may be some merit in what the complainant is saying, I will often say to doctors, maybe why don't you go away and discuss this anonymously with one of your colleagues or someone who's not been involved and see what they say, because it's really useful to get an independent pair of eyes on things. Do answer all of the points that are raised in the complaint. You would be amazed at the number of letters that come into me that have answered points 1 to 4 and I haven't even discussed points 5 and 6. And all that happens then is send you back your letter which answers points 1 to 4, and the patient simply writes back and says, well, thank you very much for that, but you haven't actually answered this and this. And then you find yourself in this kind of toing and froing. Answer all of the points. Go through the letter and highlight within it actually what is the patient complaining about here, and make sure that you answer all of those things. As we've already said, make sure that you do state the learning points. All complaints have got some learning points within them. And often those can be simple things which are to do with how the patient perceived what you said or the tone of voice that you used and all those kind of things. Try and find some learning points and demonstrate to the patient that you've taken them on board and what's going to happen as a consequence. And a really important thing is offer to meet to discuss the matter. Complaints can be, they can be very emotive sometimes on both sides. And often it's helpful to meet to discuss the matter further, particularly if something has gone wrong, because the patient can look you in the white of the eyes, and it's much easier to convey your concern and your apologies and things if they can see you face to face. And I find that meetings are extremely helpful in terms of closing things down after the initial phase of kind of the facts have been established. It can be really useful. And we'll talk a little bit later about how you might conduct a meeting and what you might do. Things not to do, don't panic. Everybody gets complaints. they're not pleasant. They kind of go to the very, particularly if it's somebody that you've tried really hard for, they kind of sometimes go to the very core of what you've been doing, and they can be very distressing to deal with, particularly if you feel you've tried extremely hard to appease somebody and that's not been enough. Don't panic, we all get them. Don't go back and amend previous notes, and this applies, for example, if something has gone wrong, and do not go back and amend the notes. The reason for saying that is because if something has gone wrong, something has gone wrong. Those are remediable. If you go back and amend the previous notes and that matter were to escalate further, so let's say, for example, somebody complains and they then later complain to the GMC, if it comes to light that you have amended the notes, not only are you facing an investigation into the fact that there's been a clinical instance, you may also be facing an investigation into the fact there appears to be issues about your probity because you've gone back and amended the notes. And that is something that it is much, much more difficult to defend. People make mistakes, things happen. Going back and amending the notes brings your probity into question, and that is something that the GMC are extremely heavy-handed on in terms of probity, as they should be. You can make additions to notes, there's no problem with that, but if you make additions to notes, you must make clear that it's a retrospective note. So if I'm doing, in fact I do it in my work as well, if I'm writing something, I write written in retrospect on, whatever day you're writing on, in relation to the events that happened on, whatever the data is that the events happened. So there's no problems with writing retrospective notes as long as it is absolutely clear that that is what you're doing and not that it looks like you're trying to amend a contemporaneous note. Don't disparage colleagues, it's really not helpful all round, as we've already discussed. And don't attempt to respond without seeing the notes. This happens quite a lot if, for example, you may be a junior doctor who has moved on to a different specialty or even a different hospital. It may be that you were performing a locum somewhere and you're no longer there. And often doctors will send us responses when they haven't seen the notes, and I really very strongly advise you not to do that. There are things you cannot possibly expect to remember every patient. You may remember vaguely the incident, but you may not remember the important parts of it. And you're certainly unlikely to remember, for example, what your examination findings were specifically. So make sure that you see the notes because it helps to add factual weight to your response. And don't, as we've already sort of discussed, don't respond in haste and repent at leisure. And, it is much, much better to take your time to provide a well-considered response that's likely to close things down than it is to send things off quickly. And perhaps not in exactly the tone you might have chosen had you not been quite so angry at the time when you wrote it. So what we're going to do now is we're going to move on to a couple of case scenarios. So you can see them there on your screen. I'm going to give you a minute or two to read them, and then we'll kind of discuss what the important points of each of these complaints are. So I'll give you a minute or two to read them. Okay, so this is a complaint from a member of families writing to complain about care provided to their mother, and you can see there what the situation is. So what I would like you to do now is go back to the questions box, and on the basis of that complaint, if you had received that complaint, what are your first thoughts about the complaint and how you might deal with it? What issues do you need to consider? Okay, so we've got some comments coming through now. So we're saying establish exactly what happened, find out what the facts were. Petros is saying review the notes. Ranjit's saying, establish the legitimacy of the complaint. Was it a cursory glance? What kind of investigation, what examination was undertaken? Someone else has said, again, sympathy for the position that they're in. Ola said, ascertain the timeline. Write out clearly what happened as a part of that. Hussam has said, acknowledge the frustration of the complainant. Tim has said, was the patient told to return if they got any worse? Discuss with the doctors involved, and Petros has said that, and I think that's really important. We'll touch on that as well, about what you do if there's more than one person involved in a complaint. Apologise, absolutely. let the Trust Complaints Office know. Absolutely. I mean, that's important. We can discuss that as well. Someone else has phoned the MDU. Very good. Very good. I mean, I think the one thing that actually hasn't come up in these comments, which I think we need to consider most importantly, is who is it that's making this complaint? In this circumstance, it's the daughter that's making the complaint, but actually the complaint is about the care provided to the patient. And importantly, the first thing you need to think about when you receive a complaint is who is complaining, and has the person who is complaining given their consent to the complaint being brought on their behalf? Now, in this circumstances, what you would do is you would go back to the daughter and you would say, I realise that you have this complaint. You know, it's important before I disclose any information to you that I know that I've got your mother's consent to give her the information. So although they're bringing the complaint, the information that you're going to provide in response is going to be in relation to the patient herself, and that information is of course confidential between you and the patient. So you need to make sure that the patient consents to the complaint. But you can also say to the daughter and give her reassurance that this will not delay your investigation of any complaint. And that's important. You can get on and do the investigation of the complaint whilst you're waiting for the consent to arrive. And somebody mentioned there about Trust Complaints Office. I mean, normally complaints will come through your hospital complaints department. But on occasion, they can come directly to you as a hospital clinician. They'll be sent to you via your secretary. And it's really important, I think, that you get the hospital complaints department involved in these cases very early on. And importantly, and most importantly, I would say, if you're a doctor working in a hospital environment, is that you make sure that you ask to see a copy of the complaints response before it goes. You would be amazed at the number of Trust Complaints Department that send responses without the doctor sometimes even knowing that the complaint has been brought. And then, of course, if things escalate and go further, you've not had any right of reply at any point in that process. So if you are either a hospital doctor, or say you're a locum working in general practice, or you're a salaried doctor who is no longer at that practice, or something like that, where you are not going to be intimately involved in providing the complaints response, ask to see a copy of whatever the overarching organisation is going to send, so that you can assure yourself that you have been represented correctly in that letter of response. So coming back to this one, the most important part of this is of course establishing what took place, but more importantly ensuring that you have the consent of the person involved. So number of the people complain. It doesn't necessarily have to be the patient themselves. A person who was treated can complain, clearly, but another person can complain on behalf of a patient if the patient consents to do so. That consent doesn't necessarily have to be written down. If you knew the patient well, for example, in this circumstance, you could phone the patient and say, look, I'm just wanting to let you know that your daughter has complained. Are you happy for me to give her information? And verbal consent is satisfactory as long as you've documented that you've had that conversation. People can complain if the patient has died, and again, the issues of consent apply here. If there is an executor of any will, that means the person who essentially stands in the shoes of the person who has died, then their consent should be sought to disclose information to anyone else. And what I'm suggesting in these circumstances is not that you seek the consent yourself, but that you go back to the person who has complained and say, clearly we'd be happy to investigate this as a complaint, but can you please provide me with the consent of the people involved? Again, obviously, if the patient is a child and doesn't have capacity to consent themselves, then anyone, the parents can complain on their behalf. And also, if the patient is incapable of making a complaint, so for example, in this circumstance, if you knew that this lady, for example, had dementia and did not have capacity to consent to disclosure of her information, then someone can bring a complaint on her behalf. If she has a welfare attorney, for example, in place, then you would seek their consent. So if we go on to a second one, I'll let you read through this one. It's a slightly different situation. It starts with, I'm a busy man. It's always a, you know, that's always going to be a tricky complaint when it starts with, I'm a busy man. So I'll let you read through that. Okay, so the busy man, he's already had to take the day off work to come to hospital. The doctor didn't pay any attention. It was late in the afternoon. The doctor took the blood. He gave him a bruise. Phones the secretary, couldn't get any information from the secretary. The sample had been mislaid, and then it turns out that the sample, that there indeed was some kind of abnormality. So again, over to you. In this kind of situation, if you receive this complaint, what things are you thinking about? What's the kind of overarching things that you need to be considering when you're thinking about a complaint like this? And I'll let you answer some in the questions boxes before. Okay, so we've got some coming through now. Provide an apology. Phone the MDU again. The message is obviously getting through. Phone the MDU. Will he ask for compensation? That's a possibility as well, and we can discuss that a bit further. Okay, Ola said send an acknowledgement letter, apologise for discomfort, give reassurance that it will be dealt with, get the notes discussed with those involved. Has the delay endangered a patient? From Angela? Yeah, I mean, that's one of the things we need to consider. You know, is there something here that has gone wrong such that there may be a patient safety issue? Acknowledge the complaint, apologise for distress, reassure that procedures will be reviewed, from Laura. Deal with the results. Can we find out what's happened to the results? That's from Jenny. Yeah, and Petrus has said this is one that needs to be addressed quickly and fully, and it may well escalate, which it may well. Provide the reasons for the delay. Yeah, and Angela said, you know, look at the bigger picture, the long-term thinking. Is there a problem with the clinic? Is this an ongoing problem? Have other patients had difficulties with the same thing? Somebody suggested we could look through the MDU website for ideas. I mean, that's the other thing, you know, whilst the MDU do have a 24-hour advice line that you can phone at any time of day or night, we have lots of resources available on the website as well that you can access to get some information and help about responding to complaints and thinking about issues at that point as well. Here's an interesting one from Jenny. What was the quality of the GP referral letter? Was it clear what the expectations of the clinic were? And also explain how things will be managed. Has any harm taken place, and how will that be dealt with? So yeah, these are important things. I think what these highlight is, and I think what you've kind of got the idea of here, is that this is a multifactorial complaint. There are lots of elements here. The clinic was running late, there was no one to take the blood, the doctor appeared to be some kind of incompetent with regards to taking blood, but again, of itself, if that had happened on its own, it may well be that would be something that the patient would never even have considered, but because they've had all of these other issues to complain about, they just throw in there, and another thing, which is why if these things could have been dealt with quickly at the time on the spot, a lot of the other things may not even have been considered by the patient to be something that they would want to complain about. So the blood was mislaid. It turns out now that there is some abnormality in the test and the patient is disgruntled. Importantly is that in these kind of situations, what you want to do is you want to consider having a significant event audit. Now this could be in secondary care, it could be in primary care. You really want to have a significant event audit to do an overarching view of what has actually gone wrong at each one of these points. So what are the key issues? Also, what are the positive points? Although he is complaining, when his care is reviewed, it may well be that there have been some positive points throughout that. And some of that might be that by the time the complaint, you know, at the point where his result was noted to be abnormal, it may well be that things were handled extremely well from there on in. So highlight what the positive points, but importantly, what are the areas of concern? What has gone wrong here? And making some suggestions to make sure that they can be reviewed. Clearly documenting what action is going to be taken as a consequence of a significant review and who is going to do it, and making sure that that is reviewed and that you set a review date at the time when you have a significant event to make sure that the action that's been suggested has taken place, and indeed whether that has impacted positively on the service as a consequence. So we said we would discuss briefly meeting with complaints. Again, I think it is extremely helpful, but it's only extremely helpful if everyone knows what the point of a meeting is, how long it's going to be, and what the important things are that you want to discuss. It's also only helpful if everyone can keep their cool. And I think it's really important that everybody is very clear about what the point of having this meeting is. The point of having a meeting is not to try to impress upon the patient that you are right and they are wrong. The point of having a meeting is to try to get things closed down, for them to have the opportunity to see you, for you to have given an account of yourself in person, which can be much, much more powerful than giving it in a letter. So importantly, before a meeting, agree what you're going to discuss and circulate an agreed agenda between everybody who's going to come along. I just this week actually had a case where a doctor had agreed to meet a patient. Nobody had actually decided what they were going to discuss. The doctor had set aside half an hour and the patient came with a 50 question document that they wanted answers to that took them an hour and a half. Now clearly what you should do is agree at the beginning what it is that you want to discuss. Importantly, I would suggest that patients are invited to bring support with them, be that a member of their family or a friend, but also somebody from PALS, independent complaints advisors who can come with them if that would be helpful to them. It can be, whilst patients have brought a complaint, it can be quite an intimidating process to come and meet with the people you've complained about, particularly if there might be you and a complaints officer or your practice manager. There may be more than one person from your side, and it can be an intimidating thing for patients, so suggest that they bring support with them. Health boards are legally required to have a conciliator, and they can be extremely useful, particularly if this is a patient who you may have had multiple problems with, or you think the complainant may get out of hand in some way, or it's a complainant that's become very entrenched, or somebody who is a serial complainer, for example. It can be useful to have a conciliator. Often the conciliator may meet both sides to get an idea of where they're coming from independently. And it can be very useful to have them, and you can certainly approach the health boards to request the input of one if you have a particularly difficult complaint. Again, as we discussed about having somebody independent there, it can be useful to have an independent clinician. That might be one of your other consultant colleagues from the department, for example, or it might be one of your partners in practice who has not been involved in the care of the patient. That can also be useful. After you've had the meeting, it's really important to record and agree the minutes of what was said so that everybody's got a record of what took place. And we're often asked, doctors contact us concerned because patients want to record, audio record meetings. I don't personally have a huge problem with that. If patients want to audio record things, then I suggest that you ask for a copy too. So if they audio record it, that you ask for a copy of it, so that everybody knows what we're dealing with. It can also be useful to have that audio recording transcribed into a set of minutes if you think it would be helpful. Again, it does depend to the extent of the complaint and how difficult a complaint it might be to resolve, but I certainly don't have any particular problem with patients recording things. So what next? What happens after you've got this far? You leave the door open for a small time. That's what I would suggest. Even if you've already had a meeting, leave it open and say, look, if there's anything else that arises, please come back to us. There will come a point where you will want to close things down, and that's, if someone is continually coming back, despite the fact you've provided a response, maybe even more than one, and you've met with them, and they're still coming back with exactly the same issue, then at that point we would be saying, I would probably be advising you to say that we need to be saying to the patient we've reached the end of local resolution. If they come back with something new, something that's maybe occurred to them later on, then I would advise you to respond to that if you can. But the point of, if you've had a meeting, you want to try and get all of the points out so that in one go, so that you can get them dealt with. Complaints need to be signed off by whoever is responsible for complaints at your organisation. Often it's the chief executive if you're in a trust, or a senior partner if you're in primary care. And you may want to formally indicate the end of local resolution if you've reached that point where you're not really getting anywhere, and you say to somebody, well, look, we think that there is nothing more that we can do at this stage. And then you would want to signpost them to the Ombudsman to seek an independent review of their complaint. The Ombudsman in Scotland is significantly less active in kind of what we call general day-to-day complaints than the Ombudsman in England. I mean, the Ombudsman in Scotland is generally looking at where multiple things have gone wrong, where it may be system failures, etc. But certainly patients can send their complaint directly to the Ombudsman if they're unhappy with how it's been dealt with locally. So moving on to how to avoid them. In some ways, how to avoid complaints is not really that different to how to practice good clinical care. We don't go to work in the morning deliberately to set out to irritate our patients such that they wish to bring a complaint. But there are some things that are helpful in terms of dealing with complaints if they do come or avoiding them in the first place. The first has got to be good communication. If you are in a consultation with a patient and it's clear to you that it's not going well, and we've all been there, I've been there, it's not going well, it's not going how you would expect, the relationship is not working, the consultation is breaking down, then say at the time, I really, I get the sense that you're not happy with this, what can we do, can we start this over, those kind of things. If you can deal with it there and then, the likelihood is that it won't progress to a complaint. You can't please all of the people all of the time. There are the complainants where that you seem to have had a perfectly normal consultation and the patient goes away and you get this vitriolic letter of complaint and you were entirely unaware. That does also happen. But if it's clear that it's not going well, try and calm the situation and start over, because that's the way to avoid them. Keep good clinical records. I mean, the primary purpose of clinical records is clearly for the continuity of clinical care and documenting what has happened. However, it is good clinical records that will get you out of bother if a complaint comes, because if you can record that you did take the blood pressure and the pulse, for example, which were normal, and the complaint is that you saw the patient and they were clearly so unwell and you didn't do anything, and then 10 minutes later they were admitted to the hospital. If you have good clinical records, it gets you out of all sorts of bother. And that's one thing you will always hear the defence organisations going on and on and on about, which is if it wasn't written down, it didn't happen. Now, in terms of a complaints response, if it's regards to manner or things that people often say, and the doctor said such and such, which is clearly something you would never have said, you can say, it would be my normal practice to deal with it in this way. So you can, in a complaints response, also revert to what your normal practice is. But in terms of providing factual and substantive information, then good clinical records often get you out of trouble. Involving senior staff in service development is really important because it's often the doctors who know the kinds of things that patients are likely to complain about. So when services are being developed or changed, or the way things are going to be done is being changed, if senior staff are involved, or if you involve yourself as a member of senior staff in service development, you are often the people who can highlight where things are likely to cause difficulty for patients and make sure that service development is progressed in such a way to minimise the opportunity for patients to complain. Appropriate supervision is important, be that if you are the person being supervised. So if you're a junior, make sure that you do seek advice of your seniors if you find yourself in difficult clinical circumstances, or, for example, in the circumstance that we were describing where a consultation or a patient interaction is just not going well, then make sure you seek appropriate supervision. But equally, if you are a supervisor, be that in primary or secondary care, you need to ensure that you are appropriately supervising those juniors that you're responsible for, to make sure that everyone feels happy doing what they are doing and competent to undertake whatever area of clinical practice they're involved in. Importantly, do take guidelines into account. This is difficult because obviously I think it's impossible to be completely 100% up on all guidelines, particularly if you're in primary care. But if somebody complains and I suggest that you have a significant event meeting, part of my suggestion for a significant event meeting is always that you look at the clinical guidance. And often you'll find that people have done things with the best of intentions, but actually if you look at the guidance, it's perhaps not what they might do. I mean, I had a recent one which was in relation to a patient who presented with a hoarse voice, and actually if you look at what the NICE or sign guidance is in relation to ENT issues, that patient should probably have been referred before they were. Now actually when you look clinically you can see what their rationale was, but when it comes down to dealing with a complaint, if the clinical guidance says refer within 2 weeks with a history of X, Y or Z and you haven't done so, it can be very difficult. And often in significant event meetings, that's the part that I'm saying that they should focus on. You need to think about your practice processes in terms of how you would refer if you found yourself in this situation again. Do work within your competence and expertise. You're far less likely to get a complaint if you're doing something that you're competent to do so than doing something that perhaps is that you don't feel comfortable doing. And of course you have a GMC obligation in any event to make sure that you are working within your competence and that you're not doing anything that may put a patient at risk of harm. And again, keep up to date, and that goes along with the kind of the aspects of making sure that you're aware of guidelines. Keep your clinical practice up to date, because irrespective of what happens with the complaint, even if the complaint turned out not really to have any merit, if your practice was found to be wanting in terms of GMC. Let's say the GMC were involved with regards to a complaint. You know, if your practice was felt by an expert who was reviewing the case perhaps not to have been up to date, then actually the complaint itself might not have any merit, but you might find yourself subject to further GMC investigation because of the fact of, you know, what you did might not perhaps be entirely up to date with what your colleagues are doing. So let's move over now to the questions and see if you have any questions that you've asked us while we've been going on. And if you have got questions on the basis of that, please do type them in the question box now, and we'll try to answer as much as we can. I'll give you a minute or two to do that, and I'll look through and see what questions we've already received. Okay, so somebody sent a question saying, how do we deal with complaints made on social media, NHS choices, and via patient surveys? These are very difficult. Obviously, we live in a very different culture now in terms of what people, the kind of areas in which people feel free to make comment about what care they perceive to have been inadequate or otherwise. In terms of social media, NHS choices, and patient surveys, for example, you owe a duty of confidentiality to that patient. And the fact that that patient is even your patient is confidential. And even although the patient may have identified you and themselves, it is not, in my view, appropriate for you to confirm, indeed, that that is the case. And in terms of things which are available on social media, I would strongly advise you not to provide any response whatsoever to any complaint that you see on social media or the NHS Choices website. Now, there are other ways to do it. So if the complaint, often people who do it in this way, they tend to write a lot of kind of emotive, sometimes quite vitriolic complaints on these kind of things. You can ask for these things to be taken down off websites, for example. You can contact the administrator and say, I'd like you to review this. And we have had a lot of success in having things removed in that way. But I certainly would not suggest that you provide any response on social media. Now, again, if social media or things get into the press, the MDU have a press office, for example, and we can advise you further if things get as far as the press. By all means, we'd be happy to do that. What I would suggest is, if you become aware of a complaint, I suggest what you do is that you write to the patient, and often I get the practices to copy over what has been written on whatever social network it is. Copy it over and say, you know, we understand that you posted this concern on Facebook or NHS Choices or wherever it might be. You know, obviously we want all of our patients to be happy. We have an in-house complaints process. Would you like us to deal with this as a formal complaint? And sometimes they'll just turn tail and disappear and you'll hear nothing of it again. Sometimes they'll come back and they'll say yes, in which case you then deal with it through the normal NHS process that you would do ordinarily. But you certainly don't do that publicly on any social media or within the kind of public domain. So let's see what other questions we've got. Okay, somebody has posted a question which says, what do I do if someone complains about me and then I have to treat them again? Can I talk to them about the complaint or do I not mention it? I think this is not uncommon. It's not uncommon that patients will make sometimes the most, you know, unpleasant complaints about you personally as an individual, sometimes irrespective of the care that you provided, and then come back to see you the next week. Now, often patients will self-select, so if patients genuinely have a complaint and they felt uncomfortable, they'll simply choose not to see you again and they'll see somebody else. If they do come and see you again, you very clearly have a GMC obligation to ensure that you do not allow the details or fact of that complaint to affect your clinical care. And that is really important. It can be difficult, but it is really important, is that you have a responsibility to ensure that you continue to provide safe care to somebody irrespective of whether they have made a complaint. Now, what you can do is, if they come in, you can say, you know, obviously I'm aware of this complaint, are you sure you're happy to continue to see me? Now that puts the ball in the patient's court then. You certainly cannot end your professional relationship with a patient as a consequence of a complaint. In terms of whether you mention it to them or not, I think this is it depends to a certain degree how well you know the patient and what the complaint is about. It would be my advice that you do not discuss a complaint in the confines of a further therapeutic consultation. So we're not talking about having a meeting to discuss the complaint. If the patient comes back to see you again for their hypertension or whatever it might be, certainly by all means you could make mention of it in passing. If it is simply to say, obviously I've received your complaint and I would deal with it, I would not go into the details of the complaint within that therapeutic consultation. The complaints process needs to be kept separate. Complaints records need to be kept separate from the patient's records, so you don't document necessarily in the patient's notes that they've brought a complaint. There are some mixed feelings about that, and we've had some recent guidance that suggests that, you know, how do you keep these records then separately? I mean, it's our advice that the complaints process and complaints records are kept completely separately to the clinical record, because it can be prejudicial to a patient's care going forward if there's, you know, if they then see someone else or they move practice or they go to a different specialty or something else. You know, patient would, for the idea that patients might be labelled as being a complainer, for example, so complaints correspondence should be kept separately. I would advise that you do not discuss it with them in confines of a clinical consultation unless they bring it up with you. In that case, I would say no more than, obviously, I've got your complaint and we will deal with it. I wouldn't go into the nuts and bolts with it there. So let's see what else we've got. Let's see. Okay, so somebody else says, in the past I've had patients go to a local journalist to complain rather than come directly to me. How should I deal with this? Again, the same thing applies as we've just discussed about dealing with complaints on social media. The Medical Defence Union does have a press office. You can discuss that with us. If they go direct to a journalist, under no circumstances would I advise you to speak to a journalist ever. And if you are doorstepped by a journalist, for example, that means they simply turn up at your door and I want to speak with you, you simply say, for reasons of confidentiality, I can't discuss it with you, and say absolutely no more. We will help you with that if that does occur. And again, I would be writing to the patient to say, look, I understand you've complained, would you like to take this further? The other way that that comes around is when sometimes patients complain directly to their MP. Now, their MP is not entitled to any more information than any other person in the street. So again, the issues of consent that we discussed earlier need to be discussed with the patient in terms of ensuring that they provide their consent for you to disclose. Here we go. This is one that says, is there a time limit before which complaints have to be made by the patients or relatives after the event? In general terms, the NHS complaints process says a complaint should be brought within 12 months. In actual fact, it would be my advice that if someone makes a complaint and you can provide a response, because you have the notes or whatever else, then you should provide a response, unless the interval of time is such that it's impossible to do so. I mean, in these days of electronic records and things, all of the information that you will need will be there in any event. It will be difficult to provide anything more than factual information if it's longer ago than perhaps 6 to 12 months, because people are not going to remember in the same way. But certainly, if you can provide a response, then I would suggest that you should do so. With regards to the GMC, for example, if someone complains to GMC, the GMC have a 5-year rule. That means that the events must have taken place no longer ago than 5 years. But if the circumstances were such that the GMC thought there was significant concern and a reason to do so, then they can waive that 5-year rule. Clearly, you want complaints brought as close to the time as possible while everybody's memories are fresh. You are not obliged to provide a response after 12 months. It would be my advice that you do so, however. Okay, and Ola has asked, when would you offer to transfer care to another physician? Again, that is something that you can offer to a patient. So you can offer a patient the opportunity to go to another physician if that's what they felt would be appropriate. But you cannot end your professional relationship with a patient because of a complaint. Now, you can steer a patient in that direction. You can say, look, obviously, you wonder whether it would be difficult for them to continue with you if they've been unhappy. Would they like to see someone else? But at the end of the day, if that patient says no, then you are not in a position to end that professional relationship. By all means, offer. There's no problem with that. If the patient elects to go somewhere else, then that's no problem. But the GMC make very clear that you cannot end your professional relationship with a patient simply because of a complaint. Again, it may depend on what the complaint is. And often, if patients are genuinely unhappy, they will self-select and they will go somewhere else anyway. But by all means, make that offer. But if the patient elects to stay with you, sometimes even if you can go through the process of a complaint and come out the other side and everybody is reasonably happy, then in fact there's no detriment to your doctor-patient relationship with them. And in fact, sometimes it can be stronger, because often, particularly if it's patients who are anxious in some way or have had a bad experience somewhere else and bring elements of that bad experience somewhere else to a consultation with you. Often if you can deal with things well, actually your relationship with the patient will go on to be absolutely fine thereafter. Let's see what else we've got here. Okay, so regarding complaints being kept separate from the notes, should letters from patients to the clinician regarding their care that might also refer to complaints or demands be filed in the notes? Letters from the patients to the clinician regarding their care. Okay, so if patients are writing in for reasons other than a complaint but may make reference to their complaint, yeah, I mean, if it's something you would ordinarily put in the patient's notes anyway, separate from a complaint issue, let's say, then yes, by all means, they get filed in the notes as they would do anyway. So if a patient's writing in to say, I'm writing to let you know what happened or whatever, and they make reference to a complaint, then yes, there's no problem with that. You put them in the notes as you would otherwise. If it's purely a complaint response or purely a correspondence rather related to a complaint, I would keep that separate. But yes, if they write in for something else and you would ordinarily put that in the notes and it makes reference to the complaint, then yes, by all means, put it in the notes anyway. How to deal with a complaint regarding advice provided on the phone. We only keep a few recorded lines about the consultation. I mean, again, I think that depends. I think that Sam, who's raised that point, it depends on what circumstance you're doing. I mean, telephone consultations should be no less documented in the notes than any other type of consultation. Often, actually, what can be helpful in phone lines, and I do this often if it's a phone-related thing, and obviously with increasing telephone triage and increasing out-of-hours calls being dealt with on the phone line, often those phone calls are recorded. And I will frequently ask for the calls to be retrieved and have a listen to them, because that can sometimes be I think people recognise that they write less when they're on the phone. Not that I think they should, but people do in general terms, as you have suggested, they write less when they're doing a telephone consultation than they would in a face-to-face consultation. Therefore, it can be very helpful to get the call recordings back, and I do that quite a lot. But again, what I would say is that it's not, in general terms, you should be writing as much in a telephone consultation as you would in a face-to-face consultation, but you do have the backup of they're being recorded or being able to retrieve them. Somebody has asked, how it's being recorded and can we access it? It will be available on the MDU website. Again, if you have colleagues or people who you think it might be useful for, it's a nice way to do some CPD, because you can do it at your leisure and when suits you, and they will be available on the website, and we will be able to send you details of how to access that when we're finished. So does anybody have any more questions at this point? I'll give you a minute or two to type. Okay, again, certificate of attendance for the webinar. As far as I'm aware, Petros, they will be sent to you by email, but I will sort that out for you. Again, thank you very much for attending. I'm very grateful. If you have ideas of things that you think might be useful, or comments that you would like to make about today's webinar, we would be very, very grateful to receive them. As I say, it's the first time we've done it, and we have been very pleased with how it's gone, but we'd be very grateful to know how you feel about it. But I'm very grateful to everybody for attending, and take care. Bye-bye.